talk a lot about, innovation and changes in health and healthcare, and a lot of people zero in naturally in thinking about advances in the basic sciences. So, for example, Carl June, a cancer immunologist at Penn, has really pioneered some incredible work in cellular immunotherapy that is making some cancers that were previously incurable, curable. But what LDI is about, and what I'd like to talk about, are some of the changes that are going on, not just in the basic science of healthcare, but in the organization, financing, management, and delivery of healthcare services that are as much social sciences as they and operational and managerial approaches as they are approaches in the basic sciences. And I think that some of the most exciting work that's going on in healthcare is, in fact, in that space, not just in the biology of health and healthcare, but in how we think about delivering it, improving access, improving quality, and if not lowering cost, at least helping to manage cost. So I wanted to start out with a kind of problem that clinicians are beginning to face and that Penn is taking a lead in addressing. And it's a perfectly obvious problem once you think about it. And the problem is this, that even if you're a patient with a chronic illness, you have chronic lung disease or chronic heart disease or any kind of chronic illness, you might be face-to-face with a physician only a couple of hours a year. But if you do the math, you spend roughly 5,000 waking hours a year doing everything else in your life. And one of the key lessons that have emerged in healthcare and health is that so many of your health outcomes are determined in those 5,000 hours of everyday life. It's whether you exercise, what you eat, whether you're adherent to your medications. And up until recently, doctors or hospitals would have no idea how you were spending your time during those 5,000 hours. And frankly, even if they did, they wouldn't have an idea of how to manage that time and how to improve your health during that time. And I think that's changing right now, and I think Penn is taking a lead in it. And it's simultaneously exciting and also a little bit creepy. And I'll point to three things that make this much more possible now. So one is that there's been a changing financial structure with how doctors and hospitals are paid, which is gradually moving from kind of fee-for-service delivery, where if the patient shows up in the office, I can bill for that, or if the patient shows up as an inpatient, I can bill for that, to a more value-based system in which physicians or hospitals are at risk for the outcomes that happen to patients even if they're not in the hospital. That creates a financial motivation to care about what patients do in those 5,000 hours, and the muscle of the healthcare enterprise is now being sort of redirected in that space. The second thing that makes this thinking possible, it sounds like a cliche, we are all so much more connected now, and the phones are substantially smarter. And it's like those old AT&T commercials, reach out and touch someone. Healthcare systems now have just a much greater ability to connect with people during their everyday lives. So that's the second point. The first one is that we care financially. The second point is we can reach out and touch. And the third really is that through the work in behavioral economics and other kinds of behavioral sciences, we have much more insight into what it takes to motivate people to make changes in their life. And we have a platform called The Way to Health, and it operationalizes our ability to engage with patients in an automated way to help them improve their health and healthcare during the 5,000 hours when they're not in front of the doctor. It's much more than telemedicine, right? Telemedicine is you and a doctor communicating maybe over the phone or over some video chat. This is where you're not even directly communicating with your doctor, but health and healthcare is embedded within parts of your life. So it might be examples of not just reminders to take your medication, but a way to help you engage with medication taking within your life. So it turns out that fewer than 50% of patients, actually only about 40% of patients, take their medications after a heart attack. Even if you make the medications free, it goes out to about 45% of people will take their medications. These are life-saving drugs, and people don't take them. You'd think you'd be scared out of your wits if you'd had a heart attack, and they're all once-a-day pills. You'd think people would do this. So we've got like all sorts of systems to help people with these little pill bottles that have little chips in them, and they alert us at Penn Medicine, this is the creepy part, of whether you're like naughty or nice in taking your medication. And you identify a supporter who is going to get some messaging. And so we can embed these kinds of technologies and these kinds of behavioral motivators into the way we take care of patients, and it is pretty cool, it's pretty effective, and it is a little bit creepy. And I'll mention one more creepy thing, and then I'll let more of the panelists talk. How many of you use either Facebook, Twitter, or Instagram? Okay, so pretty broad showing. If you were to show up for an appointment at Penn in various clinical programs, not all of them, you'll be asked that question. And then you will be asked, will you allow Penn Medicine to have all of your Facebook posts in the past and going forward, listen to you on Twitter and see all your Instagram posts, and link that with your electronic records? 80% of our patients are saying yes to that. And we are now banking, just like we might be banking their DNA, we are banking their social media posts and linking it with their electronic records. This is a program run by Raina Merchant in emergency medicine. And we are able to look for associations and correlations between what people post on Facebook and what kinds of illnesses they have. And it turns out that people who have hypertension, high blood pressure, post different things on Facebook than people who don't have it. People who are overweight post different things on Facebook than people who are not overweight. You take a guess, shout out what you think they post. Yeah, it's not food. It's relax, chill, kick back. It's sedentary lifestyle stuff. People who have or are frequent users of our emergency department post different things than people who are not. And they post about lying, cheating, and stealing, not because they're doing that, but because they feel victimized by a world that they feel is doing that to them. So there is signal in this social media. It's pretty creepy, but it may turn out to be as predictive of health and predictive of the kinds of things we can do to improve health as the information from your genome. That's why we call it the social mediome.